Welcome, everyone, to this episode of Build America, the national construction podcast that's capturing and sharing the very heartbeat of the commercial building world. I'm Kerry Smith Buck, host of Build America and also owner of Construction News and Review. And no doubt, drug tests are very familiar to employers and employees in all workforce sectors. And we have a guest today who's going to walk through an astounding survey that has research points that talk to the degree to which these tests are being tampered with, and also positivity rates that are up in sectors such as construction. I want to be sure and introduce today the specialist who's here to walk us through the research findings, and that is Dr. Suhash Harwani. And he is Senior Director of Science for Workforce Health Solutions at Quest Diagnostics. And Dr. Harwani also he holds a doctorate in chemistry from the University of Iowa, and he's a board certified toxicologist and inspector for the College of American Pathologists Forensic Drug Testing Laboratory Accreditation Program. Dr. Harwani, it is such a privilege to have you here on Build America and educate us in this episode. Thank you for being here.
Of course, it's great to be here and definitely appreciate sharing some of the insights that we have from the drug testing index.
Fantastic. Let's dive right in. And I think the first thing I would love if you are able to lay the groundwork for our listeners on the size of the study and was it across the U.S. workforce, a number of different sectors. Let us know so we have an idea of those who were the respondents.
Yeah, it's truly one of the largest population sets for the American workforce, were data sets on positivity in the American workforce. So the drug testing index, just to give some background information on it, we've been publishing the drug testing index since 1988. It's a public service to the industry. It provides a lot of insights for employers, clients, regulatory agencies, organizations, as you look at some of the insights to see how trends are going in whatever is relevant to the respective parties. And it definitely helps guide the industry. I know regulatory agencies reach out to get data at time points. Our clients do. Certain industry organizations will reach out. It really just depends on what they're looking for. Obviously, some very specific, such as the podcast today. The
Awesome.
respondents overall, we reported on over 8 million drug tests in the American workforce this year. I believe right over 5 million in the general U.S. workforce and right under 3 million for the federally mandated safety sensitive, just to give some background for some of the terms I've been using. So in the drug testing index, we report on two main populations, the general U.S. workforce and the federally mandated safety sensitive workforce. And then there's some combined data where we look at both populations together holistically. And through those, we look at, obviously, the federally mandated safety sensitive populations are those that are required to be tested under federal guidelines, if it's HHS, if it's Department of Transportation, whatever testing modes, they could be pilots, truck drivers, et cetera. Those more safety sensitive roles. And then there's the general U.S. workforce or private employer drug testing policy. In the findings, there are some caveats. Obviously, this is in the drug testing process, there is a medical review officer on the back end, not always, but in regulated testing, yeah, there's a requirement. But in private employer policy and state, depending on state guidelines and whatnot, and other legislation that employers may have to follow, there may or may not be an MRO in the process. And so the MRO's role is to verify if there's a medical reason for a positive result or any non-negative result for that matter. Our data is laboratory data, no MRO review, so we don't see anything that may have had a valid medical reason for that. So we don't have any of that data. And when we do our analysis, we do remove data sets that could help skew our population positivity data. So we do remove things that, like point of care testing is presumptively positive in the field for using an instant testing device or a rapid screening device, and we remove some of that data. So that's just one example, but there's some other examples of things we do remove from our data sets just so we don't skew our positivity. And then we do analysis trends by industry as well in the workforce. So hopefully that helps provide some background on the DTI.
That definitely does. And I know the first thing that jumped out at me when I read the summary and the release on this study was the year 2023 and the overall increase in, I know there were a couple of different points that the survey covered, but the humongous over 600% increase, if that's correct, in substituted urine specimens. And that just blows me away. That is that high. And then I'm wondering, what is that 633% increase overall for the US workforce sector? What are some of the factors you think are behind driving that enormous increase?
Yeah, so obviously, so you are correct on the percentage. The percent was over, it was 3% in the general US workforce. And the federally mandated safety sensitive, believe it was right above 370%. Both populations did increase in terms of substituted specimens. The invalid rates also went up, maybe not as drastically. They were closer to 50% increase. But both went up drastically, right? Year over year from 2022 to 2023 data. And I don't want to say it's a driving force. Obviously, the methods that the laboratories use to detect substituted invalid specimens, it exists for a reason. Obviously, we're detecting things that are intended to be detected. And fortuitously, right before we formally presented the drug testing index findings, I believe it was a DAPC that presented right before us. But it was a federal government agency presentation, and they speculated. They reported a similar finding, so it was nice to have two corroborated data sets back to back. And they believe the finding to be from a product that's on the market that was misformulated and that the laboratories were able to detect. Our data definitely shows large increases, and it sounds like they were seeing that at a holistic level for safety sensitive data in general when they reported as well. Obviously, there's tampering going on in the background, but that's the holistic idea behind urine. It's not an observed collection. You need a private bathroom space to do the collection event. So when there's a will, there's always a way to make something happen. So there's going to always be those nuanced parameters of people trying to get around drug testing because they are using or whatever reason they may have from that standpoint. But I think the other focus, has to be on, there's newer matrices out there that can help get around some of this, like observed collections. Oral fluid, I know DOT, HHS have both approved it. I know there's no regulated testing laboratories today, but it is allowed for general US workforce private employer policy testing, but it's a fully observed collection as well. It may not be where urine is today. Urine has been the gold standard of the industry, but it is definitely moving forward. It definitely has support to move to the regulated level once there's a laboratory and a device that can do oral fluid regulated testing. But from a standpoint, are there shifts that will happen from a technology standpoint? And that has changed where we are ready to start implementing or getting to the implementation of oral fluid into the programs more holistically, similar to what urine is today.
That would have a dramatic, I would think, wouldn't you think, dramatic influence or impact on the validity of the test and of the person being tested. I would think the margin for tampering would be greatly reduced, if non-existent, maybe. That I didn't know there was another standard that we could see.
Yeah, there's definitely a lot of value in oral fluid drug testing. If you look at some of our data, and we try not to read the more recent time points specifically because of marijuana. So 2022 and 2023 data, maybe not because of the decrease in TH testing for marijuana. So that skews some of the data in overall positivity for the more recent years when you look at overall data, but oral fluid positivity is generally higher. Some of that designed, obviously, it's an observed collection. There's that piece that sits behind it. There's cutoffs, obviously a different matrix. It has different parameters that you have to look for. And so the cutoffs are different. They're lower than what urine is. And that's just inherently what the matrix is. It's not necessarily that they are lower and you're comparing an apple to an apple. They're two different things. So they have to have different cutoffs. But I know SAMHSA has proposed cutoffs in their guidelines and whatnot. From that standpoint, there is an industry standard at this point in what to look for.
Oh, that's amazing to me. Since we do focus on the construction industry, I wanted to be sure and ask you, there's another facet of this news release and the testing that was done, or the survey that was done rather, and it talks about positivity rates. And I know that Quest Diagnostics has broken it out by industry, and I looked at construction, and that appears to have been up over this same period of time, 2022. And I wondered, how do those construction industry positives compare with other sectors and maybe with the construction industry itself, say 2, 3 years ago?
Yes, we present a 1-year trend, and we also usually provide a 5-year look back. We do give a look back, and obviously in the middle of that 5-year look back is still a pandemic. There could be some nuances from that in there, but I think we get lucky since we're comparing to 2019 still and not to 2020 data yet with that 5-year look back. But when you do look at the construction industry, more specifically, we do see an overall year-over-year change of 11% increase in positivity, which is below the national average of, it was below the national average of 5.7% positivity. It's right under that. The exact percentage, I think, was 5.2% overall positivity when we look at the construction industry itself. And when you look at the 5-year trend, it was up 24% over that 5-year time point. I don't want to say it's like, it is definitely up. There are industries higher than that, but it just depends on the nuance of where we are today societally. Obviously, a lot of the major drivers that we see in terms of positivity, there's two pieces of it. I think two major pieces. There's some other nuances that you see in specific areas, sectors, and whatnot. But you do see a marijuana effect. Obviously, the easier some substances to obtain legally at a state level, obviously you would expect that there's going to be a higher frequency of use at that point. No different than what we would see with anything else that's legal to obtain. And then there's obviously been a high prescription use for amphetamines as well. Amphetamine itself, not amphetamines as a class, where we do see positivity increases in amphetamine year over year as well. And I think the trends for the construction industry resound those same sentiments in a way. You do see a 20% increase year over year in marijuana positivity, and then a 6% increase year over year for cocaine as well. So
Wow.
there are some other, and that's where I say some of the nuances, like amphetamine may be sitting there. Actually, I think construction did see a decrease. I can confirm that, but for amphetamine itself, but year over year, but obviously you make up some of that with potentially other drugs, which may be nuanced by industry itself.
Did they separate it out at all with the study of, let's say for construction, administrative in-office people versus out in the field? Because that, I think, would be interesting and perhaps frightening for an industry that is dangerous when you're not taking drugs. I can't imagine the ripple effect or the impact on workers out in the field building projects.
So you're talking about like the same construction company that maybe has an employee in the office versus one that's in the field. Yeah, those are caveats of the study. When we look at industry data, we have to we can only provide one coding classification because we don't necessarily see, since the drug testing is, I don't want to say fully anonymous, right? But we don't track donor name.
Right.
Do we get that information in private policy? We may have some of that information, but we don't generally look at it. It's not clinical testing, so we don't see some of those data points. We usually use specimen ID for everything. From that standpoint, we can't actually break apart within and a nuanced data of that. We do have, like, year over year in some of our reporting, you will see some of the industries potentially come and go from our data reporting because we do have a minimum requirement of 50,000 data points for reporting the industry data. There is some, obviously construction is always, I don't think it's always been there in our data reporting, but we do have some minor nuances that we can't break it down. There could be a manufacturing company but we may classify it as manufacturing, but they do have other job functions in there. So we unfortunately, that is a caveat. We can't break it down that deep because we don't have that level of data within the actual entities that we receive specimens from.
No, that makes complete sense. From an employer perspective, not only in construction, but just broadly in those two classes that you mentioned, the U.S. workforce, the private employers, and the federally mandated safety sensitive workforce, the air traffic controllers and the physicians and others. What do you think is the employer takeaway from this latest research? What's the best way to combat, speaking specifically the drug positivity rates, but we could also talk through the specimen substitution or fraud rates. What should employers do?
So I think the one thing that obviously the data helps guide, and this is part of the intended purpose of sharing the data. It's helped to adjust or analyze the data, get insights from it to potentially adjust your drug testing policy or an employer's drug testing policy. I think we see a lot of trends. We do see overall positivity when you look at both workforces combined at 4.6%, and we've seen that for the last 3 years. But it's up from the lows that we saw from 2010 to 2012, or 3.5%. Knowing that we are still seeing sustained highs from within, when you look at that last decade-ish range, from 2012, decade and a half, 20 to present, you do see continued trends of upward positivity, which is, and not necessarily from a safety sensitive, depending on how safety sensitive the workforce is that you have and what the goal is of the policy, and crafting that policy right in the proper manner is important. I'll give one example, well, two examples. One is the implementation of oral fluid. Obviously, some employers and clients may choose to do that based on state regulations as well, where they can't do certain testing and they may want to continue. Marijuana is one example where you may not be able to test for urine metabolite, which is the predominant reporting mechanism in urine for the industry. So they may have pivoted to oral fluid, but having a well-balanced program between oral fluid and urine, or oral fluid itself, and knowing when to pivot to urine or vice versa, that's one piece of that puzzle. And then there's the other piece of the puzzle of looking at how you do your testing. You can do pre-employment drug screening. You can do, obviously, post-accident. Those are probably the data points are probably the largest from a pre-employment standpoint, but if you're doing pre-employment, you're doing it on every employee that you're hiring. So it's a larger data set for most matters. And then when you look at post-accident, obviously, it's very important to employers and clients because they want to make sure they minimize those scenarios. But I think there's understanding random populations behind it, random testing. When you look at random testing programs, and we've done a data set, and we've looked at small data sets, we don't know at scale if a lot of our clients' employers have random programs, but we can pull subsets of data where we do know that some employers may have random programs. And when we look at that data, and this is true for when you look at safety sensitive data versus general US workforce data too, but when you look at when there is a random program implemented, we see relatively flatter overall positivity and post-accident rates versus what with programs where we can identify them. So holistically, and the caveat I put there is that one is holistically all of the data. We see increases year over year in terms of when we can't identify or we don't know. And then when you look at federally mandated safety sensitive overall positivity, it's always lower in terms of overall positivity. When there's an expectation to be tested, is there an impact on drug use and how donors think about using drugs, knowing that there is an expectation that I will be tested? I think there's a lot of factors, just using the data to help make sure you analyze, or whoever's reviewing it analyzes it, takes it in, and tries to use it to adjust as needed for their policy. I think there's a lot of value in a properly crafted drug testing policy. I think at the end of the day, we have to remember that there's a donor on the backside of all of this. There's a drug testing piece behind it that clients and employers want to ensure safety in their workforces or in their workplaces, but there's workforce wellness behind this as well. How do we ensure that, because we're looking at both illicit and prescription drug use, how do we take those pieces and realize that there's a donor, everybody has life events that impact us. Somebody has to go onto the substance use disorder side. You could have a surgery and get pain medication and then have an outcome from that where you have an addiction to a pain med. How do you impact overall wellness from that aspect as well? I think there's a holistic viewpoint that is coming about. I know there's recovery ready workplace stuff that is in the background going on as well. So remembering that they're not necessarily bad outcomes. They're outcomes that we can derive data from. And how do we shift our focus to understand that there is a donor sitting on the back end of all these and focusing on that wellness piece to ensure that, because no matter if it's prescription or illicit use, obviously that speaks to potentially the wellness of the workforce as well.
So well expressed. We appreciate on this episode of Build America having Dr. Suhash Harwani, who is Senior Director of Science for Workforce Health Solutions at Quest Diagnostics. And Dr. Harwani, this has just been eye opening for me, and I know our listeners as well. And with your permission, I would love to post this news release and the detailed findings on our website so that people, if they want to look at more, they can learn more about the study.
Of course, yeah. I was like, it's out there, it's public data. I was like, it's out there for everyone to use. So yeah, feel free to post as you need or you feel is helpful for your viewer base.
Wonderful. Thank you. And for those of you not familiar with the website, it's Construction News and Review, and it is www.mycnr.com. And Dr. Hawani, it has been just such a privilege to learn from you today. And I know employers are already going to take this information in the construction sector and elsewhere and learn how to, again, view the donor as an important part of this equation of making a workforce, making their workforces healthy. So thank you so much for being with us today on Build America.
All right. Thank you so much for having me. It's been great to share some of our insights. And definitely, if there's any questions that pop up, always feel free to reach out for sure.
I will, and I hope you'll come back on again. Thanks so much.
For sure. Thank you.
Over to it.